Good morning, everyone. Welcome to our monthly peripheral endovascular webcast at Mount Sinai, New York. I am Karthik Guja. I'm the Associate Director for the Endovascular Program. With me is Sardar Farhan. He's our Assistant Professor here at Mount Sinai. Today, we're going to go over a very interesting case. And then the next monthly live webcast will be on March 24th, same time as you guys know. And the previous cases are all archived into our website. And if you guys have any questions, we'll be very happy to answer all the questions you have. And without any further delay, let's go to the cath lab where Dr. Krishna and Dr. Kapoor are waiting for us for an exciting case. Good morning, Dr. Krishna. Good morning, Dr. Kapoor.
Good morning, Karthik. Good morning, Sardar, and good morning to everyone. We're really excited to have all of you here. Couple of notes prior to starting. All of us here are big golf fans, and prayers to Tiger Woods and for his speedy recovery. Very tragic in this last year for all these things to happen. Second is this case, and I think this case is really going to be a great discussion. And Karthik and Sardar, we really need your help in making some of these decisions that we're going to have to make. But I want to introduce the team. Everybody knows to my right, Dr. Vishal Kapoor, who's the Director of Endovascular Services at Mount Sinai, Mount Sinai Morningside now. To my left is Ray Lascano, our endovascular nurse practitioner. To Vishal's right is Shreya Avadani. Forgive me, I'm like blanking here. Shreya Avadani, and Shreya is our endovascular fellow this year, and we're happy to report that she'll be joining our system next year as one of our additional peripheral attendings. And then to her right is Mahi, who's our future structural fellow, and really excited to have him. Very talented coronary interventionalist, very talented doctor, and very, very happy to have him part of this case. Again, our team here is Elizabeth, and then of course we have Damien outside. Raman Sharma is in the control on the outside, and we're happy to go ahead and start. So we have a very interesting case, Karthik and Sardar, and this is a challenge that I think all of us face every single day with these type of lesions. So I think it'll be very interesting to have a great discussion. So Shreya is going to go ahead and start us off with this presentation before we get to our work. Slides, guys. Yep.
Good morning, everyone. So just going to go over our case today. She's a 62-year-old woman with history of peripheral arterial disease, had prior peripheral interventions, presenting with right calf pain with minimal ambulation that has been progressing to rest pain over the past 2 weeks. On exam, she had diminished but palpable DP pulse on the left side, and present on Doppler on the right. No skin ulcers or wounds, Rutherford Class IV. In terms of her PAD history, she had a right SFA intervention in January 2019 with PTA, DCB, and DES to the proximal and mid SFA. That was a Zilver PTX 60120. She also had left SFA interventions in the past between 2016 and 2018. Most recently, she presented in September, was found to have a right CIA stenosis with a gradient of about 30 millimeters of mercury and underwent a bare metal stent placement. So since then, she's been on Plavix and Xarelto after a month of aspirin in addition. Other medical history, diabetes, hypertension, hyperlipidemia, and she's been a former smoker but quit a long time ago. Her labs and medications, grossly within normal limits, slightly elevated LDL, and those are her medications, like I mentioned. She underwent a vascular ultrasound, and these are the results of the non-invasive study. And as you can see, top right at the proximal osteal SFA, there's a pre-occlusive thump, followed by no flow in the mid SFA, and distally she had monophasic flows below the knee. Left side. And do you want to review the pictures now?
We'll skip the angiogram. Yeah. We'll just go right to the discussion. Okay. So Karthik and Sardar, she had a very complex intervention of the left SFA in the past. Interestingly, it was one of those where the SFA to tibial collaterals. Her profunda is very, very, how can you say, diseased. So when we did that intervention, we knocked off the SFA to distal collaterals, and we basically created an acute limb situation. We were able to salvage it endovascularly. Everything went fine. And we had put her on Eliquis at that time, a long time ago, because of the amount of thrombus that we were dealing with while we were doing the intervention. So she's actually been on, prior to even the new trial, a NOAC as well as, what is it called, Plavix. So she's been on really, really good medical therapy. Her LDL has been hard to control. You saw it was on 85, 86. She's on max dose of Crestor, and we're now considering adding Repatha to her regimen. Obviously, we're not her primary care team, but yet we're trying to manage her guideline-directed medical therapy. She's a very active lady, but this case, I'm going to have Vishal just play the angiograms as we start. This case, go ahead, Vishal, play the angiograms. This case really shows, you can see we got contralateral access, and you can go next. Yeah. And then you can see here that you have a beautiful iliac stent that we had done for the last intervention. Next. And then you can see here that you have exactly what Shreya described. You have some disease in the profunda, and then you have this tight, pre-occlusive lesion in the ostium of the SFA, followed by total occlusion. Next. And then you can see here that she has a mid-SFA is totally occluded, and she has a proximal stent and a distal stent, which are both gone. Next. And then at the distal, you have a large collateral that from the profunda that forms the SFA in the adductor canal. Next. And then, or above knee popliteal, I should say. Then, healthy popliteal, great bypass segment. Next. Mm-hmm. And then you can see here that she has very healthy anterior tibial artery, a little bit of disease in the what we call as the TPT or perineal, if you want to call it, and then a very robust perineal artery. Next. All the way down to the foot, which shows that she has very good flow in the foot. So the question really becomes is, this is what I meant by a challenge. I mean, multiple challenges in this case, right? One is how do you cross this because you have a normal segment or a non-stented segment between two stents. Two is, you've got, how do you treat? You've given her contemporary best-in-class therapy with drug-eluting stents and drug-coated balloons, and you've now dealing with restenosis. That's a long segment. And so that's kind of where I want this discussion to go. Shreya has done a nice presentation, and we'll get to that. But I just want to start off with this. Before we start, I just want to show you what we did. We went ahead and used an angle Aquatempo catheter to engage the SFA. Can you show it from outside? Oh, it's going to play. Yeah, you can see here that we just without a wire go in and actually get into the actual ostium, not getting behind the stent. Next. Then we just use a straight glide, and that's exactly where we are. So our plan here, Karthik, while we cross, is obviously not to get into this other stent strut here, and then just be able to take the wire all the way down, and then we can start. But I just wanted to talk about, as we do this, maybe you and Sardar can talk about what we should do to be able to treat these lesions, and what are the options we have in therapy, and how you guys deal with that in your practice. Go ahead. Uh-huh.
I think technically, even before options, I think this is very challenging, right?
Go ahead, Ray.
I think the main difficulty is you have a gap of native CTO in between both the stents. Mm-hmm. So, I think you had a good stump on the top, so that's a good sign. So you were able to get into the stent from there. The problem will be here if you're in a dissection plane, unless it's thrombotic, the chances of you getting behind the stent here is very high.
Okay. I agree, Karthik, and watch your knees, Ray. I totally agree with you. And what we're going to do is we're going to go very slow. And I think one of the techniques that we do advanced therapy catheter is that we're going to get really close to the strut before we actually move in. So I'm just going to advance this, right? And then see how it goes off to the side.
Yep.
So come down, Ray.
Yeah, that's the most common difficulty you face.
So right. Now we're going to switch out to probably an angle glide wire. What would you guys do? I mean, this is a challenge we all face.
Sardar?
At this point, when the wire is pointing towards the stent strut, so that you are dissecting outside of behind the stent, would be actually nice probably to get an 014 wire. Try to get stay in the true lumen. or probably find a different plane from a little bit above as you're doing it right now.
Yeah. So what we're really trying to do is just find another plane. And now I'm not going to advance yet because I'm going to ask Ray to watch his knees, because what we really need to do is really go to different angles to make sure we're not behind the strut. And you see here, we're actually quite lucky. And as Ray moves out of the way, you really, as endovascular interventionists, need to go to all different levels. So I'm going to have Ray now advance it. I know it's difficult, he's reaching, but we're going to advance it. And what we're going to do is interact with the strut. And as we interact with the strut, we're going to learn how this works. So if this works really well, and it behaves well, then that's fine. So he's having trouble there, so we're going to stop.
It seems like you're behind the stent, PK.
I agree, buddy. I agree.
Yeah.
I agree. We'll see. But what we can do is we can advance the wire a little bit, right? We're going to loop it now. God willing, it loops. Nope. See, over there we're behind, but not up top. See that? Now we know we're in the stent.
Yeah.
So now Ray can be really aggressive and push. Now there you go. So that's an important thing. Save that, guys. So Karthik, as you know, if the stent had buckled, and it's happened to all of us who deal with this, if it had buckled, then you're behind the strut. And it's very important not to push, because if you create a second plane, right, Vishal, on behind it, then you're in trouble. So why don't you guys, Ray and I are going to cross this. We're going to place a filter. Why don't you talk about different techniques, you, Vishal, and Sardar, if that happens, how people should deal with it?
Right. So I think that's a very important point, is getting behind the stent strut. So like Sardar was talking about, one of the options is, which I would usually do, is actually scale back and go onto an 014 stiff wire, maybe one of your CTO wires, Confianza, Astaro, Win, any of those high weight tip wires, to try to see if you can puncture through one of those dissection planes and try to go intraluminal. So that's one of those techniques we always try to do, finding a different plane. But being aggressive, especially with a catheter, actually can get you into more trouble, because we are creating like bigger dissection planes and hematomas, which can make it more difficult to re-enter. So I think that's a very important point, is to make sure when you're entering, try to be as conservative and less aggressive. You know how in CTOs we are very aggressive, loop and all this stuff. But in this case, I think it's very important to make sure we give due consideration to the entry point of the stent level. What do you think, Sardar?
I totally agree. Totally agree.
The question is, the question comes is, when, if you, let's say, in between both the stents, you're even unable to even enter the second stent. The options are, what would you do then, Sardar?
I think, having a stent in the distal SFA is actually might be a chance for getting a direct SFA access with a micropuncture kit and with the dilator of the micropuncture kit. Probably by this approach, you will ensure that you are in the stent, and then you can externalize the wire from there, and then take it down to the communication between the distal stent and the begin of the popliteal artery here. This is one approach. The other is to try to find a re-entry at the proximal cap of the proximal stent with a stiff 014 wire.
And one other way to do it is, you can use an entire balloon if you want.
Correct.
Behind the stent, and then try to go in a different angle and go into the stent strut and do it. That's one. If worse comes to worse, that's probably the last way to do it.
Well, I think you guys highlighted all the strategies, but I think, remember that you could definitely direct stent access is one. Second thing is 014 wire. Just to recap what Vishal said, 014 wire with the directional catheter. Third is actually you can cut the catheter and actually pierce into the dissection plane and then go in. Fourth is, like Karthik said, the anterior balloon is another good one to be able to try to get in. Or a re-entry device if you want to spend the money. And fifth will be obviously the pedal access, and can come from below all the way up without a sheet just to cross. So these are the 5 things, but I think the best thing is recognition of when it happens and not create a plane parallel to the stent, and then now having to deal with a large 4 French catheter hole to do it. Now that we've crossed the first 3 challenges, I would say, is now this area, and Vishal and I want to stop here to talk to you guys about this, is, okay, now we're at the distal cap, and you can see here it's obviously a blunt stump with a large genicular collateral, or a large profunda collateral, I should say. And now the question is how this is going. I want to show you how this wire behaves, right? So as I push the wire, you see how the wire is sort of gliding next to it. So I'm not pushing that hard because I'm trying to see whether it pops, and it's not popping. So I want to give you 3 options. One, option A, push the wire and pop it through. same wire that you have, maybe reduce the loop a little bit. Option B, go with a straight glide, okay, and try to enter with a straight glide. Option C, go with an 014 wire or an 018 wire and try to enter directly into the cap.
I would actually go with an 014 wire PK.
Okay,
Third
that's
option,
one.
That's because it's a huge collateral and it comes right off of the head of the stump.
Okay, which wire would you use, Karthik?
I would probably use a confianza wire here, sure.
Okay, so confianza type CTO coronary wire, right?
Yeah, because you can get a clean entry, and I'm assuming you're not going to stent this area anyways. At some point, I mean, I don't know that. We don't.
Well, we don't know that yet.
We don't know that yet.
Yeah.
We don't know that yet. But our goal is not to stent in this area, right?
Right. So Vishal, what would you do?
I'll probably go with a straight 035 glide wire.
Okay, and Sardar, what would you do?
I would take the first option with an 014 wire.
014 wire. Shreya, what would you do?
Probably the 014.
Okay, so Vishal is outvoted 3-1, which he's used to, because remember he has three beautiful ladies at home, and he always gets outvoted, so he's always used
Nothing
to
new
that.
for me.
So nothing new for him. He's not going to be hurt. So let's go with an 014 wire, and so give us a confianza type wire, whichever one we want. So Karthik, in terms of wires, peripheral wires, and you too, Sardar and Vishal, what wires do you guys really like? In these kind of lesions.
So I mean, I guess this, like we were talking about, the most of the time CTO wires. Here we start with the confianza because I guess we have more than enough experience with how the confianza behaves. It gives us good directionality if you make the right CTO curve, and also it has weight and body to it. We use the Confianza Pro 12 here as one of the wires, but you can have, we've tried our Staro 20, 30, 40, works great again for crossing CTOs or the wind wire. So any of them, whichever makes you, I guess, more comfortable. 018s have, of course, more weight to it, so it's easier to use it, but that's what we start with, usually a Confianza.
So for the record, I would have gone with a 035 straight, Vishal. But again, I wanna say, can I have another wire, please? Because I forgot how to.
No, the reason I was talking about
Confianza.
the reason I'm talking about 035 is, again, you're right. I mean, we don't want to create another dissection plane. It looks a little fibrotic, calcified right there, and we have to give due consideration to the collateral. But an 035 stiff wire without the catheter, if it crosses through, at least it gives us again a pushability. Like you see, if we have a loop, we don't have much pushability at all.
But I want to highlight what Karthik and Sardar and Shreya said, is that I think with the 014 wire, our dissection plane potentially is going to be a lot less.
Yep.
And what Karthik said is very, very important to everybody at home, is that huge collateral is going to influence not only how we cross, but it's going to influence how we treat. And I think that's what we're going to have a great discussion on. First, let's cross this, and then we'll talk about how we're going to treat this. So I think obviously before we treat, we're going to have before I tell you what we're going to do, after I cross this, I'm going to have Shreya quickly go over what her presentation that she's put together regarding the treatment options for ISR, and then we're going to go ahead and talk about what we're planning on doing and why. So let me first cross this. So I'm relying very much. I'm just getting it down there. Yep. I'm relying very much on Karthik and Sardar into the collateral, right?
Yep. Which is expected, which is probably the anterior area. So
there you go.
That's it.
So that was very nice, right? So we're able to get through, and so Vishal and I stand corrected. I'm also.
So PK, this is why I didn't want an 035 wire, because
makes sense. Go.
Yeah, I felt like we would probably pop into the collateral first than the main vessel.
Not going.
And the 035 wire would probably give you much.
Yeah, no, it's not going to go. So yeah, part of this is going to be our rail and our pushability, right? Because of this catheter, so we might have to switch out for a. Give me a little digest. An 018 catheter.
I mean, you have to take an 018 anyways for the filter, so you might as well just take it.
But the worry is, will the filter cross? You know that filters can be very finicky, as you know. And so the only issue is, will the filter cross? Yeah,
you have you already created an 035 track, so I think filter will cross. So
no.
Trailblazer or a
Angle.
CXI?
Yeah, you're good.
Get us a CXI.
CXI.
Yeah, get us a CXI.
CXI catheter.
Oh, well, unless you got the Trailblazer already.
We have the Trailblazer.
Oh, that's fine. It doesn't matter. Okay, anyway, I'm going to park it here.
Yeah, I think you're already committed to that vessel.
Yeah, exactly. I just want to... And then now for the filter, obviously, we can use any filter we want. But we're going to go ahead and... I didn't cross. But I think we're going to use the Abbott EmboShield here, which may or may not cross here, guys. because it's pretty tight at the distal edge. We'll try.
But I think if the 018
Got it?
Trailblazer crosses, so I think it's fine.
It should cross, yeah. All right, so Shreya, when we deploy this, why don't you start right now? Mahi
Okay.
can help us with the filter, and then you can go ahead and start presenting.
Go ahead.
So go ahead.
Let me switch from here.
Yeah, let's look at the sheet. Let's go. Let's go to the her presentation. There you go.
Yeah,
Go ahead.
We have it.
Fix the wire. Just want to make
Fix,
sure it
you got the
doesn't
word?
Um,
Sorry.
further
Yeah.
down. What is supposed to go? Or come back.
Okay.
I have the wire. Okay.
All right, so I'm going to just start going over the Tosaka classification for in-stent restenotic lesions. So this was a paper published in 2012, a multi-center retrospective study of 738 patients with ISR that were divided into 3 groups and labeled as type 1, type 2, and type 3
Wonderful.
lesions
Let's get the
based
other
on the lesion type. So focal, less than 15 millimeter long
got it.
lesions were type 1. Greater than 15 millimeter long lesions were classified as type 2, and total occlusions were type 3. And there was about a third of patients in each class. And these patients were followed over time to look at outcomes based on the ISR subtypes. All of these lesions were treated with balloon angioplasty and followed for about 2 years of follow-up. And this is data from the paper that shows basically having a type 3 ISR lesion correlates with the worst prognosis in terms of freedom from TLR and freedom from, sorry, I just want to look at the monitor, and freedom from reocclusion at 2 years. And
Perfect.
so, and essentially not much of a difference between the type 1 and type 2 lesions.
Good.
Also,
Perfect.
predictors of recurrent
Then I see
ISR were found to be either class 3 type lesions and lesion length, and also the reference vessel diameter, and also the presence of early restenosis, versus predictors of recurrent reocclusion were similar based on lesion length, ISR subtype, and also the reference diameter, which was interesting. So basically, at 2 years follow-up, the recurrent ISR rate for type 3 lesions was almost 50%. In type 1 and type 2 lesions, and about the same in type 2 lesions. Versus at 2 years' time, the recurrent occlusion rate was 64% in type 3 lesions versus around 15 to 20% in the type 1 and type 2 lesions. So basically, it was concluded that the pattern of restenosis is an important predictor of recurrent ISR. So these are some of the therapies we have available for in-stent restenosis. Essentially, balloon angioplasty and cutting balloons limited by high restenosis rate up to 65 to 70% at 6 months. There's also other therapies like the Viabon endoprosthesis that was evaluated in the RELINE trial and also has an FDA approval for treatment of ISR. And also drug-coated balloons, drug-eluting stents. Laser, which also, again, has approval for treatment of ISR. And also, I'll go over some data with directional atherectomy and also rotational thrombectomy in ISR. So just going over the
we can open the rotor.
Viabon trial that looked the RELINE trial that looked at the endoprosthesis. So basically, they were looking at whether a barrier between the vessel wall and the blood flow would be beneficial in preventing recurrent restenosis. So in this prospective multi-center randomized trial of patients with Rutherford between 2 and 5, about 88 patients equally distributed between the 2 arms treated with the endoprosthesis versus regular balloon angioplasty. There was a much higher patency rate with the use of the Viabon endograft. And freedom from TLR was also higher in this group as well. And it was also found that the Viabon group was 3 times less likely to require TLR at 12 months. some of the DCB trials in the use of femoropopliteal ISR include these that are summarized: the debate ISR, the FAIR, PACUBA, and ISAR PBIS. They're all pretty small trials of about anywhere from 50 to 100 patients, looking at outcomes predominantly around 1 year. Essentially, the underlining that the use of DCB is associated with better patency, less TLR, and also in some of them clinical improvement with the use of DCB compared to plain balloon angioplasty. This was a meta-analysis that kind of included 4 randomized control trials and compared outcomes over 12 months, and essentially also summarized that the DCB group had much lower TLR and recurrent ISR, and also improvement in the Rutherford class compared to regular balloon angioplasty.
Yeah, I know. Okay, good.
The just a list of the available DCBs: Impact, Stellarex, Lutonix, and Ranger, and their length and further details about these balloons.
You have to tear it, right?
So we also have one trial looking at whether re-DES, like we do in coronary ISR, might be beneficial also in the periphery. So this was a trial of Zilver PTX, 108 patients with 119 ISR lesions. That was a single-arm prospective study that they were followed over a period of 1 year, I believe. So this included about a third of patients with long lesions and a third of patients with also CTOs. Basically, with the use of drug-eluting stents, there was a higher patency at 6 months and 12 months. You can't really compare it to the DCB, but in close to 95% at 6 months and 78% at 12 months. And freedom from TLR was also anywhere from 80% at 1 year to 96%, but it drops to about 60% at 2 years. There was also a improvement in Rutherford class and an improvement in WIQ and ABIs. And they found a 1-year fracture rate of about 1.2%. This is basically underlining the primary patency and freedom from TLR in the Zilver PTX arm, basically. Other therapies that are also used for ISR include laser atherectomy, which uses UV light to basically vaporize tissue and photoablate. The fragments that are released are less than 10 micrometers. There's little effect on calcium. Mostly best works for pliable lesions, either within the calcium or soft plaque in that's usually culprit in ISR, and also works on material behind stent struts to allow for better expansion of the stent. Basically, 2 setting parameters, the fluence and PRF to adjust. The fluence being the energy that's required for the penetration of the UV light into tissue, and the pulses per second. These are the available catheters, the Turbo Power and the Turbo Elite, that are most commonly used in the periphery. The Turbo Power has the indication for FemPop ISR, comes in a 2.0 and 2.3 size, and the 2.3 is compatible usually with the 7 French. And these are some of the trials that looked at laser therapy in ISR lesions. Initially, the PATENT, which was a single-arm registry of 100 patients that basically found better patency rates, with patency rates of about 60% at 6 months and 38% at 12 months, not too reassuring. But it did show that essentially the 12-month patency rate was no different between the 3 classes of ISR, maybe concluding that you need something in addition to laser therapy for treatment of it. So this was followed by the Excite ISR, which was a randomized trial of 250 patients distributed 2-to-1 between laser atherectomy and balloon angioplasty versus just balloon angioplasty. And basically showed that your primary efficacy endpoint, freedom from TLR, was better in the group that underwent laser plus balloon angioplasty compared to just balloon angioplasty, and this was a statistically significant difference. This was a summary of the efficacy and safety endpoints, basically everything except for more distal embolization, although statistically non-significant in the laser group. Okay. In terms of combination therapy, laser plus the drug-coated balloons, there was a single-center randomized trial a small trial of 48 patients, essentially pointing to better outcomes with the use of DCB and laser. Do you want? Okay. Directional atherectomy. There were a couple of trials limited by high TLR and TVR rates, almost 30% and 24% in this very small trial of Silver Hawk, also limited by high macroemboli. So I'm just going to skip now to the some of the other combination therapies, the use of atherectomy with thrombectomy devices, particularly the Rotarex and the Jetstream catheters. That combine some form of rotational atherectomy and are also capable of aspiration. So this is the Rotarex catheter that's basically designed in a cylinder, a cylinder around a helix with windows on the side. And essentially the cylinder is rotating to cause essentially a rotational effect and cause an increase in acute luminal gain. And at the same time, you also have a second aspiration helix that's constantly on that essentially creates a vortex and a suction effect for the debris to be collected within the catheter. These are the available catheters and the sizes. They're all usually 018 compatible, and they come with their own wire. Treats vessel diameters anywhere from 3 to 8 millimeters, and has both 6 French and 8 French systems available. In terms of data behind the use of the Rotarex system, we have some pretty small trials of ISR lesions. This one from Italy that includes iliac and femoropopliteal arteries with ISR, and that were treated with the Rotarex. In the 30 patients followed for about a year, primary patency at 30 days was good, about 96%, but around 1 year comes down to about 58%. Small amount of complications, including dissection, perforation, and hematoma as well with the device. There was also about 18% late mortality, and this was attributed by a sicker population that was followed by the authors. This was also kind of a pilot study looking at the efficacy and safety with Rotarex and DCB in 32 patients, an observational prospective registry. And primary patency was a little bit better with the use of DCB, around 86% at 12 months, and freedom from TLR about 89%. And there was an improvement in ABI and your clinical parameters as well. The other catheter that's similar is the Jetstream by Boston Sci. Also has a rotational and aspiration capacity, compatible with an 014 wire and also a bare wire and filter. Same with the Rotarex as well, as you'll see. This one has a option of using the catheter with blades up versus blades down. So essentially a single cutter versus double end cutting. And usually it's the XC catheters that have the blades up option that allow for more plaque modification, essentially. And some trials that looked at ISR specifically with the use of Jetstream, again, small trials, about 30 patients that were treated pretty successfully, and patency essentially 72% at 6 months, and TLR about 14 to 20%. This was from the Silver PTX trial, just basically comparing. I know it's not a fair comparison between all of the trials, but essentially looking at patency rates at 12 years between the use of all of these therapies And so far from what we have, the Zilver PTX looks like, highest patency rates at 12 months, around 80%, versus laser, and then followed by, I think we need more data from the
Wonderful presentation. A lot of information, Karthik and Sardar and Vishal. Now having done this now, so like we talked about, this is a challenge that we all face. A couple of questions for you. One, does atherectomy add anything to this, or should we just do our therapy? Two, if we are going to do a therapy, which therapy is it that we're going to do?
Okay, I think the question is, I think the way your glide wire crossed, I'm assuming there is some component of thrombus there.
Of course.
At least in the first stent. I don't know about the second one. The second one, I think you still had a difficulty making a loop and pushing it through. I think the first one definitely had some component of thrombus. So I would definitely try laser atherectomy for sure. Or we can go with something like, I think, I don't have much experience with it. I think Sardar probably does Rotarex, which is a new device which is coming in, I think, from Bard. I haven't used it, so I can't comment on it. So I think Sardar, probably you. It sucks, and I think atherectomizes and aspirates at the same time, if I'm not wrong. So.
But let's before we decide on, okay, so you have a vote for some sort of atherectomy aspiration.
Yeah.
Sardar, you also agree with that?
I agree with. I mean, as Karthik was mentioning, that it looks like it's a thrombotic component, like a majorly thrombotic component leading to this occlusion. So probably a thrombectomy modality with, as we mentioned, with laser probably, or with the Rotarex, or with a jet, with an angiojet might be the choice to start with, to see how the flow looks like especially between the stents, because there after getting at least a little bit lumen, we might see that whether there is any need for further plaque modification with a true atherectomy rather than a thrombectomy.
Yep.
So I'm also voting for the same.
Vishal?
No, I think I agree with them. I mean, we've known from our experience that ISR, there's always a component of thrombus sitting up there. So debulking by getting the thrombus out and then defining the anatomy with an atherectomy obviously enhances our visualization, probably getting the mechanism of why things failed, and then probably make a definitive treatment strategy. So again, thrombectomy with possible atherectomy as well.
Agreed.
So, okay, well, I want to push back a little bit and really be a little bit, provocative. I think one is, Sri and I talked about it yesterday. We don't know what is the component makeup of this material within the stent and in the occluded segment. We actually did a PubMed search, and maybe we're not as good as others, but what we did in our limited search could not find anything really that popped out that looked at histopathological analysis of peripheral arterial in-stent restenosis to look at what is the material. Actually a surgical excision. We know in the coronaries that's been done over and over again in postmortem specimens, and we're very clear on what it is. So we don't know what we're treating. Having said that, I think what Karthik and all of you are really saying is that you have to learn from the wire passage, right? So the wire passage, since I was the one who pushed the wire, I would say it was all not thrombotic. I mean, maybe the segment in the middle with the non-stented segment wasn't. But within the stents, Ray was pushing the catheter. He'll tell you we had to push quite hard to try to get through. But having said that, I'm sure there is some sort of underlying, old thrombus that's caked on. Now, what are the devices? I mean, laser. Shreya did a great job of going over everything. But I want to go over between on-label and off-label, right? And Shreya said, obviously, Silverhawk atherectomy is off-label in ISR. Laser is on-label in ISR. Jetstream, I believe, is on-label. Correct me, somebody with some text messages if it's not. Rotarex is on-label within Europe, off-label in America. And I want to be very clear, we're not promoting off-label use of products. But what we wanted to tell you is we've been doing these cases now. This is probably our 105th or 6th case. We've done laser in ISR. We've done Jetstream in ISR. We've done Silverhawk in ISR. We've done restenting ISR. We've done Reline in ISR. And I can tell you the results have not been the best. And and the question is why. So I think we want to demonstrate a newer device that has very limited data, as Freya presented. But again, it's exciting in that the device works really well in our hands. We've done about 8-9 cases now, and we're very happy with the results we get. We're getting it with very limited embolization. Now, having said that, we always use a filter when we do any sort of atherectomy, any sort of intervention in a long segment ISR. So we have an EmboShield down. I just want to show all of you. So we crossed, and while Sriya was giving the beautiful lecture, we put an EmboShield down, and the EmboShield's a 4/7 EmboShield that's all the way down. And now we're going to go ahead with the Rotarex device. Vishal, can you just talk about the device a little bit?
Yeah, so like Shreya pretty much talked
Shreya,
about
go
it.
ahead.
No, go ahead.
No, I mean, so it's pretty much an aspiration and an atherectomy device with with like a tubular structure in there, where the whole idea is to improve. This is without the blade, so as if they're used to Jetstream, it comes up with blades. This is just without the blades, which does the atherectomy part of it, and also in addition does the aspiration. So when you're doing an atherectomy, thrombectomy, so to say, it's helpful in ISR cases, and it comes with its own O1 wire, sorry. But in this case, again, because we have a filter deployed and we believe in filter deployment, we're going to use it on a filter wire.
Again, off-label.
Again, off-label, right. And the device, the good part about this device is, you'll expect a rotational device or something to have a pedal in it like the other ones have. This one comes in with an option of the hand operated system. So if you want, you can just use a click at the back end, and it's like a magnetic system that actually attaches to itself. So there is no alignment or metals or anything. So it's just pretty much a magnetic option which turns the rotational atherectomy thrombectomy on it. So, and this is the back end of the wire where the wire comes out, and we just pull it back. And
so when you lock the wire, it prevents the wire from actually moving as you move the device, which is very, very important. Okay, right. So the device moves independent of the wire. The other thing is the drainage port. Can you show?
Yes,
the
I'm sorry
port?
about that. Yeah, so this is the drainage port, which is hooked at like a side port where all the aspiration part happens. It's nicely hooked up to the outlet, so you can see how much clot burden, how much blood is being sucked out, and then you can see if it's clogged up, you pull it back, you flush it, you clean the catheter, go back in.
So, so a couple of things. We're going to load it on, and we're going to go. A couple of things is that you want to be very, very careful in terms of your advancement and also how this particular device reacts. We've done one in ISR in the past where advancing it was very difficult because of the bias while it was spinning, but we were able to pull it back under the on mode, for lack of a better word, and got a beautiful result without any interaction with the stent struts. So again, I think our knowledge of this in America is growing, but again, this is an off-label at this stage, and I think you have to be very careful when you do anything off-label. But again, I don't think we have anything effective that's standard of care at this stage in these kind of lesions. So we're going to go ahead and we're going to advance this. Again, I got the wire way down so that there's no pulling of the wire. I'm going to come down slowly. And again, the arch is another important thing I want everybody to consider. If it's a very narrow arch, then you really need to go ahead and use a 7 French sheath. Comes in 6 and 7 French systems. Okay, so what I'm going to do just before we start, just to dot our I's and cross our T's, look down, make sure my wire is well distal. I've got my filter well placed, nothing has moved. I'm going to come back up. I'm going to mag up really high. And I just want to go ahead and just start slowly, right? I mean, is everybody okay with the way things are looking at this stage? So everybody's happy, and now we're going to start. Go ahead.
Mm-hmm.
So very slow movement. Very slow movement, and now we want to see the aspiration come. So I'm going to use a little bit of a pecking movement here. I want to see the aspiration come. And you got to put it down, guys. It's got to be gravity driven.
Yeah, it is gravity driven.
It's coming now.
There it comes. I want to see everybody see the aspiration. And you see, whenever it decelerates, I'm going to come back and forth here. I want to really allow the Rotarex to do its work. So so it's decelerating. I'm going to come back again.
Hold it up.
Hold it up, yeah.
Mm-hmm.
There you go. Notice as it's doing its work, the deceleration allows me to come back and forth, and very slow. Elizabeth gets a little nervous because of the amount of aspirate that comes out. But generally speaking, this is not as big a deal. And Ray, she's moving. Anything going on that I should worry about?
We're not getting lifted up again.
So, the Lord. Get off. Any dolor?
I
I
think
think
because
we
it's not
stopped.
Like you don't have to,
Yeah.
Senor,
getting any
Senora,
flow.
dolor?
you have to hold the wire.
What? Yes? Okay, no problem. So what I'm going to do here is I'm going to advance this down.
Hold on.
I'm going to do something, don't pull the wire.
I am not.
Just going to advance it past this segment. On again.
I think it's the eccentricity of
On again. I think it's the vibration of off. Now you see that?
Yeah, you
you
see
see what
that.
happened there?
Yeah.
Which shows the aspiration of this catheter, which is fine. I don't want you to worry.
It
But I
takes time
wanted to demonstrate how much aspiration you're getting, and what she's feeling is the stent vibration as this is spinning. So I don't want you to worry too much about it, but I want you to obviously be careful and go very slow.
PK, correct me if I'm wrong. Like normally
on
when
again.
this happens in when we're doing the angiojet,
Yeah.
it's a sign that there is no tissue there. It's all thrombus.
Yep.
Yeah, because it's if there is a restenotic tissue, usually you don't see stent getting sucked in like that. You don't see the movement like that. That's all tissue where you're having right now. So whenever see now you have done
And this looks really well working, yeah?
yeah.
Now we're going off. So she's having a little bit of pain.
Oh.
So this
So
is
remember,
all
we're
this
not
is all a
getting any-
dissection
Yeah,
plane,
we're not
right? So I
getting
don't
much
think it
because it's all
matters at this
blocked
point of time. So
So at this stage, what I'm going to do is I'm going to see how she does. I'm going to give her a little break. And what I want to do is just push it down to see how this thing behaves, okay?
PK, do you have to
I'm not going
atherectomize
to
it
go
here?
on. I'm not going to go on. I'm just going to let it go. Let go of it, Vishal. Allow me to go forward.
Yeah, hold on. Let me
Dr.
gonna
Krishna,
hold it, yeah.
do you really have to atherectomize it here? Because the chances this is probably a dissection plane, right?
Let me see. See, it's not going, Karthik. So it is a
Yeah.
dissection plane, but it's not going.
Yeah.
Walk it back a little,
So
Vishal.
I
So I'm
mean,
just gonna go
using
very
this
slowly.
device in a dissection plane probably is not. She's going to have a
Well,
lot of pain, right?
But I like the way it's sort of centrally located, the wire.
No, here I'm saying I'm talking about the native vessel
Come down.
Right.
It is indicated for native vessel.
in a dissection
know?
plane.
Yeah.
It's okay.
Well, I don't know if it's okay. I mean, in a dissection plane, I mean, what really is okay in a dissection plane, right?
Right.
Let's go on.
Yeah. Hold on.
Off.
We're
Okay,
really
I'm just
Not getting much blood flow back. I
Mucho
think because
dolor. Mucho.
I think the CTS segment we're not
Okay,
getting
no
blood.
problem. No problem. Flora.
Is it?
Don't-
do you
don't-
think
don't
it's
come out.
advisable to take
I'm
like a
not.
4 balloon, create a track, and then go back in and
I think
redo
that's-
the distal
well,
stent?
Yeah, I think I don't want
That's
to push
exactly what I was going to do. Let's walk it out. Let's give us a 3-0
Because-
balloon, guys.
Yeah, if she's having pain, that
Yeah.
means
Well, I just think you're definitely very adventitial.
Yeah,
But what we'll do is
yeah.
we'll balloon the non stented segment,
Yeah.
and then we'll go back in.
yeah. My
with
concern is
this.
stating it too much, and when you balloon it, you might perfect.
4-0
so I
balloon is
don't want
fine,
it to-
guys. 4-0 balloon. Well, last time we did it, she didn't. The patient didn't have any pain. So we are being very respectful of the fact that the patient is having pain, and we'll go ahead and go with a 4-0 balloon.
good.
Can I have a 4-0 balloon, please?
Yeah, I think it's because it might be a section, might be subintimal, and you might.
Can I have a 4-0 balloon,
Yeah,
please?
yeah, it's coming.
And you can also see, Karthik, there's not much blood coming out after that ISR segment.
Yes.
So
Can you
probably
please-
even in the occluded subintimal part,
Yeah.
where there is really no flow, and that's why she feels the adventitious stretching
Okay.
and cause you
A
to have
4-0
pain.
long balloon.
Do you want to take
80 to 120 is fine.
I think definitely the way your wire went in the distal stent, that's all atherosclerotic. Okay, because you had a really hard time pushing in the distal stent. So I think Ray was trying to push it really hard, if I'm not wrong, right, Ray?
Yep,
Yeah.
it's fine. It doesn't matter.
No.
So yeah, I mean, I think it's all conjecture at this time. I don't think we know unless we do an IVUS,
Yeah, yeah.
which maybe we should have done. But I think at this stage, with her having pain, since she was very comfortably sleeping, makes me feel that we should go with a balloon angioplasty to see where we are in the non-stented segment, and then go ahead with the Rotarex in the stented segment. Again, our experience is very limited with all this, and I think we're going to be
Right.
very, very cautious, which makes sense for us.
You got it. I'm
So
ready.
I'm just going to go ahead and just do the non-stented segment. Don't pull the wire, please. Vishal, as you all know, who've seen this, very notorious at pulling the wire and blaming me. So we'll go here. Okay, right here. Let's go up here. So we'll just go with a small 4-0 balloon. We know it's at least a 6-0 vessel. So now, while we do this, Karthik and Vishal, as well as Shreya and Sardar, what's the story with in terms of our final therapy here? Yeah, she's having pain no matter what we do here.
10,
Yeah.
12.
12, 14.
Yeah,
I don't know if it's a plane, but she's having pain. That's all. Down. Okay, walk it back a little bit.
Mm-hmm. Hold on. Flora,
A little more.
take it into the stents.
More into the stent. Okay, go up there. So what would you do? You guys avoiding the question here. Final therapy.
No. I think we were just trying to see how she behaves.
I know.
So I think
14.
It is 14.
I would probably I mean it's a good 2-vessel runoff, so I would have no problem relining this, especially if she's having so much pain.
Let me
That
see
means
the
it's
process
very
on the stent.
advantageous.
Okay there.
So I don't think doing a
Up?
DCB is going to work
No.
here anyway. So what do you think?
But
I mean, yeah.
go ahead.
No, I was just confirming.
Well, my only question is, when you reline, you have a distal collateral, right? That distal, and we don't know the mechanism of failure. How is she, Liz? We don't have the mechanism of failure, right? So did it fail because of the stents,
Yeah,
or did
we're
it
on
fail
DSM.
because of something else? Give me a little bit.
Yeah.
So PK, I mean, when you have such a big CTO between two stents, and
good.
especially you know that
We don't have
CTO
an
is not
operator
a
below
thrombotic
the distal
CTO
part.
Yep.
in the native vessel.
Bring it down.
So I'm assuming the failure mechanism of
Right.
failure is the native vessel restenosis and causing total occlusion, right? That's why when you have a complete stent, when you have completely metal down and the full stent, then you can talk about multiple ways of probably restenosis or thrombosis or anything. But you have a native vessel in the middle, which is a chronic total occlusion. So I'm assuming it started from there, and then both the stents got probably.
But why would the distal stent restenose if it's starting
because of lack of flow,
proximal?
right? Because of
No.
low flow, right? Because if the
Low-
native vessel
low flow,
closes, there
but-
is no flow.
But you still have a large
over-
collateral distally that could retrograde
That's-
flow, and
that's-
we've all seen it. Right? We've all seen it in these cases where where one stent stays open because of the large collateral and retrograde flow. What's my ACT, Liz? Okay.
I have a
good.
feeling that's why probably the distal one is restenotic, because
Okay,
over
ready?
time it might have
Don't
I'm not
restenosed. So
Hold it up.
the low flow
Yeah,
state.
yeah.
So
The wire came back. Nope. Yes, it did. Hold on. Let me just push this wire forward a little bit.
you can take it. It's making a loop there.
Yeah.
Yeah.
Yep. Now I'm okay.
Well, let me lock the wire.
Like I said, not Shreya. Vishal, you know how he is. Okay, ready?
Notorious, yeah.
Okay, notorious. On. Again, very slow. Right? Allowing it to go forward.
Anything coming?
So here you
Nothing.
see the stent studs are not coming in much.
We're not getting any flow.
It'll come.
Yeah.
So it looks like this is more of a restenosis than.
Getting
I think
flow now?
even if you
No.
don't
No.
get much flow, I
Did
think
you
it's
flush
okay,
it?
PK.
Did you flush
I mean,
it?
it's probably.
Flush it, Shreya?
Did you flush it slow?
Floated in
no,
there.
nothing.
Yeah.
Did you put it in the water afterwards?
No, not yet.
When I took it out? All right. So anyway, this is a new device, and this is part of it. So what you have to do when you take it out
Let me lock it up.
is run it in water, right, to be able to clean out the particles that are within the screw. I'm just asking the BD folk out there: is that true that you have to go ahead and run it in water when you take it out of the body to clean it out?
Well, yes.
Yeah, so that's I did ask our team to do it, but again, obviously we were talking, and sometimes when you're live, things get lost. So we're going to go ahead and run it.
I think it's just a clot of that sitting right there.
It's going to clot in the catheter, not over there, Shreya.
Okay.
Open. Yeah.
Yeah, but we'll just do it this way. So I think part of it is you're going to have to just go ahead and run it. Make sure you get flow, because you don't want debris within the catheter.
Go ahead.
And then that's the key. So when it flushes, that's the thing.
No.
Yeah.
There it
Yeah.
comes. So you see now you have water coming, and you have to hang the bag across over the side of the bed, because it works by gravity. Guys, let's hang the bag
It
on the
is.
side of the bed, please.
It is.
On the side of the bed, it should be hanging. Thank
there.
you. Is the water coming?
Yep.
Slow though. It's not like free flowing as it should be.
It's coming very slow. Does that mean we have to change the catheter because we clotted it? Let's change the catheter. Give me another catheter.
Now it's coming better. Well,
No, let's change the catheter. So, guys, I think part of it is out there. There's a new device. Our team actually is not obviously used a lot of it, but clearly this is something that we have to be very
take it
careful
out?
with
Just
when
put
you
it
take
out?
it out of the body.
Yeah.
It's a very small lumen. And because it's a small lumen, Ray, can you detach the catheter for me?
Yeah.
Because it's a small lumen, you have to be very careful that it doesn't clot off.
Got it.
So can I have another catheter sometime before tomorrow morning?
Well, I think because we haven't really distally opened up the vessel, that's why we're probably not getting any grub down
No,
there.
but I mean, when you're aspirating, blood should come out. I mean, I think
Well-
that's what the audience has to understand in terms of what is, when you take the catheter out of the body for whatever reason, like ballooning, you need to make sure that you flush it. Okay. And I think that's very important. And and we'll go to the videotape because I did say please flush the catheter. So I think it's very important that we flush it.
As you said, PK, I mean, at least personally, I have not used this device. So I think I think you probably have more experience than anybody on this device as of now. I don't think even Vishal used it much.
I'm sure a lot. I mean, in this room probably, but
in this room, I'm talking about. In this room, I'm just saying,
in
like
the country, I'm sure a lot of people.
I think that's why
Is there
probably
a
our team is a little bit probably lagging behind. Otherwise, normally the devices we use.
Hold on, flushing. I need a back
pretty
first.
good at
Otherwise,
it,
it's going to
We
come
have-
out.
Right. So I want to show you the difference in how the flow is, so you understand. You saw in the last one there was no flow, and Sardar and I did it on again off-label reason a couple of weeks ago, and the flow was very robust, right, Sardar?
Yeah.
So this is a very good aspiration device. So when you don't see that kind of aspiration, you really have to consider whether the inside of the catheter is clogged. And that's going to be important because part of what you're doing is trying to go ahead and doing this, So you can see here, you can't touch anything. See now, look at the flow.
I'm not touching anything.
Nice.
I'm in water.
I mean, it's
Now
water,
now
we
look at
don't
the flow.
see it very well.
Well, no, it's still. You can see it up here, but look in the bag.
Yeah.
It's exactly the same way.
Yeah.
All right, all good. All right, good. We flushed it.
Still trickling.
Let's go through. So,
Because you think if it's more thrombotic, you get more robust flow than if it's more restenotic.
See, that's what I was talking about. If it's a lot of thrombus component with good inflow, of course, you're going to see much blood
You're going
flow.
to see a lot of flow, right? But if there's a lot of
if you're in a
restenosis
CTO
there,
segment, all you're going to do
you're
is the
not gonna see
atherectomy
much,
part and
yeah.
not the thrombotic part.
but Karthik, it's very important with this device to have flow. If
Sure.
you don't
Okay.
have flow, you're just going to be kind of spinning in the same area.
I mean, makes sense, yeah.
It's very important
Sure.
that you have to be careful. If you have any reason to believe there's no flow, better out to take it, flush it, and then go for it. That's what I would do.
Sure.
Now we're going to go start again. Now Vishal has to lock the wire.
It is locked.
Oh, it's locked now. I'm going to
You
check
lock,
the
you
distal
lift, you elevate
filter is good. And now we're going to go again on.
Now see the stent gets squeezed.
Yeah.
Yeah, which it didn't
See
before.
that again.
It's coming.
Yeah.
Trickling.
Okay, Sardar, if you say so.
But that's how it comes.
It is.
So it did come last time.
It is
But
what
that's
it
how
is.
it comes with the new one. It is what it is.
It is what it is, exactly. But I think it's important when you don't know a device to err on the side of caution.
Yeah.
When you don't know a device, always err on the side of caution. Make sure that we're doing it the right way, right?
Nothing.
And I think that's
Not
what's
much
important.
Nothing is coming.
Okay. Very slow movement.
So what is your plan to do after this, PK?
I was waiting for all of you to tell me.
I said that, Sardar. I'm waiting on Sardar and Vishal.
I mean, depending on the flow, either we need to do further modification of the lesions, or we can actually start talking about our definitive therapy. So Sriya was presenting all the available destination therapies. It sounds very appealing to use Viaban, a covered stent.
Squeeze it.
But as Dr.
Are you
Krishnan's
squeezing it?
worry was
My hand was right here.
regarding the distal collateral,
He wants
we
you to
should be
pin.
very careful using
On.
that and should use it only if really need to. The other question is, since the patient had already two drug-eluting stents which failed, we might consider using a DCB and leave nothing behind other than the already implanted devices. This is also a strategy. And in these cases, I believe we have to accept the fact that there might be a limiting step is that there will be in-stent restenosis or re-occlusion again.
Right.
And at that time, we should consider
Bypass options.
bypass options.
I
if the
think this
patient-
patient has a very good bypass target. So
The problem is who's going to bypass for claudication?
For claudication,
Yeah.
absolutely agreed. But this is
but she's having resting pain now, right?
Off.
Because she's Rutherford Class 2 and 4.
Okay,
So
back.
when she's progressing to resting pain,
Okay,
so
stop. Go forward on again.
yeah, the distal cap was a little bit tough, right? Yeah, that's it.
Off. Okay, walk it out. So we're not gonna go through the distal cap. You gotta unlock it.
Yeah, it is unlocked.
Okay, just watch the wire and just walk it out. So press and come out slowly. Press and come out. Press and
I
come
mean,
out.
there is
On.
blood
Oh,
in
you
the
want
back,
to? Oh, you want to do it?
as Sri is demonstrating.
All right, Sardar.
Slowly.
And now you have brisk flow because
Off.
probably the artery is patent now.
Yeah, because you're in the.
Okay, walk it out now.
I don't know if it's brisk.
Lot of pain. So get us a balloon, guys. Get us a 5/0 long balloon. Okay,
You have the wire?
not yet. Have the wire.
Would it make sense, Dr. Krishnan, to do an
Wait.
angiogram?
Okay, give me a balloon, guys. 5/0 long balloon.
Quick.
5/0 long balloon.
He's getting in.
5/0 long balloon,
He's
please.
getting
Open
in.
up,
He's
open up.
getting in.
PK,
I
do
don't
you
see
want to
any
take a
swelling
picture?
at all.
Do you want to take a
Let's take a
picture and
picture.
see?
No, not yet, not yet.
Okay.
I don't see any swelling. She is very sensitive.
Yeah.
No, Elizabeth told me earlier on because we were prepping for direct SFA access. She's very sensitive. So this is not something that I'm very concerned about, but I'm just putting a balloon down and then we'll take a picture with a balloon there.
Okay.
Okay, Rail?
Well, go.
That makes more sense.
Okay, Mama. Okay. I mean, we want to show everything that happens, so it's not like, what length is this balloon? 150. You don't have 200. When I said long, is 150 long, guys? I don't understand.
Even 300
All right,
would have been
give
okay.
me give me a little die now. Let's just make sure. Okay, there's no perforation. Very good.
She's
So
good-
there
she's
is
good
there is
flow.
no perforation, Rail.
Well,
So we're just gonna now balloon it with a 50150. I want everybody to see that there was no perf. So okay, I'm gonna go across the collateral here because I have to.
Yeah.
So we're gonna go ahead and balloon it. Okay, Mama, no problema. Let's go up. Okay. So we're gonna balloon this. Okay, 6, 8, 10, 12. Okay, well, good expansion there.
Yeah.
Right.
Yeah.
That's wonderful, yeah.
Okay, wonderful expansion there, right? Okay, down. Thank you, Vishal. Down. And now we're going to go back up to the other stent here. So we have to balloon, and we see the expansion is so easy. We did undersize the balloon a little bit. I'll go up now. Oh, nope, you got to get it overlap. I'm sorry. Okay, right there. This is the area.
Yeah.
Now I'm sort of convinced with what Karthik is saying. Okay, Mom. Can we give us some more sedation,
I think
guys?
that's where she's having the most pain
yeah.
in that tissue area. Probably pop it, Vishal, a little bit more.
I'm at 14.
I think
It's a
at least
5/0.
one time pain is better than having
But it's a 14 right there.
yeah,
Okay,
go
down.
higher also.
Well, I think it's a 5-0, so I think
Yeah.
we're going to balloon it. We'll balloon it bigger. Now let's not come out of the stent.
I'm
A
gonna
little
keep
bit
it in
more,
the stent,
A
yeah.
little bit more right there.
should be
Go
good.
up
There's
there.
a stump anyways, so it's
Yeah, exactly.
Maybe a little bit more proximal.
I'm just a little worried about the profunda.
You'll be fine. You're in the stent.
10, 12, 14, 16. Okay, down. All right,
Leave the
so
eccentricity
now the
of the
stent is,
balloon.
so it looks like to me the mode of failure is what Karthik said. It's not the stent, it's the mid-segment.
native vascular.
Just because of the way the two stents responded. So I want to make sure that my filter doesn't move because we don't know if it's full. And now we're going to go ahead and take a DSA picture, and then we'll decide. So for those of you who followed us in the past, obviously this is not our regular room, and unfortunately we're limited by the length of the picture that we can do. So let's look at the mid-segment to make sure we don't have a perf. If it's going to perf, it's going to perf in the native segment, right? Whoops.
Yep.
Can I have injector not ready? You coupled it. Uncouple
I think
it,
her
please.
stents have opened
Yeah.
up pretty well, so I think it's going
Let's
to be a
see.
native vessel. So
If it's a perf, we have to
If
deal
it's
with
a
it.
perf.
So there is no perf.
Wow.
yeah, nice.
Wonderful.
So we
flow,
thought we
actually.
and see look at the image, the way the Rotarex worked on this case. It's amazing.
Yeah.
And you can let's look at the stents, and then let's decide whether we're going to put another Zilver. The stents are clean, so I agree with Karthik.
Yeah.
I think there was some restenosis, but I think the stents are clean. I think it's the mid segment that failed.
the
And I want all
collateral
of you
still
to understand
patent,
is that one of the things that Dr. Sardar, myself, and our team here at Sinai are working on is understanding how DCBs and DSs are
Sure,
failing.
so looks good.
So the issue is at this stage, it looks like these stents are very healthy, and we can IVUS it. But I want to stent that mid segment after
Yeah,
vessel
I
prepping
would
it.
definitely stent that mid segment.
Yeah. So let's
prepping
vessel
it.
prep it now. So give me a large Dorado.
I would do a DES there, no, PK?
Yeah. We're
Yeah.
gonna do another Zilver now.
6-0.
Yeah.
But what about doing a DCB of the ISR segment?
Well, is it really ISR? That's my question.
I don't think so. I mean, I think
Well,
the stents are
I don't know,
fine.
without
Let's
IVUS-
ask Michelle.
I don't
This
know,
is again. I want the audience to know, Michelle. This is the reason we're presenting this because we don't know what
Right.
to do.
So
This is a difficult situation, but I want all of you to look at. It's an off-label use of the Rotarex. Look how clean this artery is.
Yeah,
You saw a
200.
completely occluded artery.
5 or 6.
You can do. We've done laser, we've done jet stream, so on and so forth. It's a device that seems to work really well. We need to know more about it. I need a 6.0 balloon, guys.
6-0.
Yeah,
I need a 6.0 balloon.
200.
And Liz, she's going to have pain. 6.0, I would give you a
Well,
6.0
When are those
200.
stents placed? I'm sorry, PK. I think I missed
About
the
a year
part.
and a half ago.
Ye-
Year and a half ago.
Okay.
So, I
And
mean,
they're, and they're both DES, right? So
They're both Zilver PTX.
yeah.
well, I guess, again, the question again goes back to how did your wire behave initially to go
Well,
with? If you-
it definitely felt tough.
Right. So if you're not IVUSing, which probably an intravascular imaging might give us
But
some
again,
idea.
IVUS is very hard to tell between thrombus and ISR.
I understand, but it's all about the the atherosclerotic, the
atherosclerosis,
neoatherosclerosis happening with ISR. Is that
My only
that
question
what's
is,
another
Vishal, if
confounding?
you look at it, right, we only used a 4.0 and a 5.0 balloon. I'm sure these stents are 7.0 stents, right, PK?
6.0, 6.0.
6.0, okay. I mean, the luminal gain you got just with 5.0
Let
is
the wire
pretty
come out.
significant luminal gain. I mean, I think we can DCB it. I don't think
Yeah.
there's any
But
any downside in DCBing them, but it's other than the cost.
But I also agree with Vishal's point that we can accept the fact that
Yeah.
Watch
that
don't pull the
redrugging those stents might be an option with a drug coated balloon. Is that what you were trying
Yeah,
to tell us,
exactly.
Vishal, right?
Yeah.
That was the whole thought process.
Yeah.
If,
Okay,
if that's
guys,
adding to the
this-
issue,
This is going to hurt.
if you want to increase,
Let me go
Go
down
in
a
a
little
little
more.
bit more.
Yep, hold on. Okay. Okay, this is going to hurt. Okay, get a cover.
150 stent. This is a 200 balloon,
200 balloon.
Go up.
so she'll need a 150 stent at least.
All right, we're just going to go up.
2 silvers.
Okay,
I'm going to crank up.
we're going to go crack it.
They should just come up with a 200
Zilver
DES.
PTX,
Yeah.
10.
Go.
I mean, those are 6.0 stents and you have a 6.0 balloon, so 1 to 1. So
20.
you want to be careful a little bit.
16.
18, 20.
PK,
expand.
1 to 1, right? That's a
We're
6.0
going
stents.
20.
I know, but
going
they are 6.0 stents with a 6.0 balloon.
That's fine. What
Yeah.
can you do? It's not going to rupture. And it's a non-compliant balloon.
There.
See, it's opening now. Go, keep going. Now, you have to be understanding that you may rupture this, right?
Yeah, probably
Yeah.
that's what it's going to
So
happen.
down. And then let's see. Now, this area, I'm just going to give it a little dye just to see what we're dealing with.
I'm not concerned about the native vessel. I'm more
Okay.
concerned about the in-stent part
Oh,
with the
there's a-
6.0
Yeah,
to
we've
6.0.
got a little bit of a perf going on there. You can
Yeah.
see. Go up
Yeah.
to
That's-
4 atmospheres.
That's why.
So we may crack and pay this now. Give me a covered stent. Go to 4.
I am.
150.
Viabomb.
150 would be
That's
enough.
it.
We have-
150 Viabomb. That's it. 4.
We have
See
I'm
the
going to
way-
include this.
we
Yeah,
need
because
one.
you see how the
We're going
way
to
it
get the
behaves.
150 Viabomb. Stop the max. We're going to stop the max. So we're going to
That's
put a
actually a very
150
good
Viabomb.
solution. Yeah.
Well, I mean, look, I think I always say this as a joke, but you either got to poop or get off the pot. I think at
Agreed.
this stage, if you don't crack this lesion, you're going to have definite ISR.
Because
So that's one of the reasons why
Yeah,
Sri and I
agreed.
talked earlier,
Yeah.
and we talked about what are our bailouts, and our bailout is we have a Viabon available that we can put in. So we can put a 150, we can put a 200. It doesn't really matter, and it goes through a 6 French sheath. So this goes into the planning of the case. So right now, Vishal adeptly with his hawk eyes saw the perf, and so I think what we're going to do is we're going to go ahead and place a vibe on, and then pave and crack. Is it crack and pave? It's crack and pave.
Crack and pave.
But we're going to pave and crack.
Right.
We're going to pave and crack.
We already cracked it. So
We already cracked only part of it, V.
That's true, though.
So you didn't really follow the dogma.
Vishal is
Today's my day,
pooping and
Karthik.
sitting. Vishal is pooping and sitting, not sitting and pooping.
Today is just my day.
Oh, he's sitting on the pot, not pooping on the pot. All right. I love the word poop, don't you? We should talk about the what is it called? The etymology. Is that the study of words?
Yeah.
Right.
Yeah.
Right. We should talk about how the word poop came up. Because we all, those of us who have little kids, you go,
It's a
did you poop?
150. Yeah.
Interesting. All right, 60150.
All right.
Karthik, I'm trusting you with the sizing.
So I guess the perf made our
150
decision
is good.
easy.
Perfect.
Right.
All right,
Karthik?
so now, Damien, my friend, we're going to need a Dorado. I'm going to need a 60, like a 100 Dorado. So, guys, now we're going to work really fast. We know we have a slight perf, so I'm going to go AP. And all I'm
You're
going to
just
do
putting
is...
a stent. You're just putting the stent. I know, but we just got a small question. This question is the tape. They're asking where to exactly position our tape.
Okay, now
when they're putting it in.
Yeah. So why don't you answer that, Karthik? While Vishal is going to wire this a little bit.
The thing is, we want to put it in the area of where you want to do the intervention normally.
No.
So if you're putting it in the thigh, you can put anywhere in the thigh as long as it's in the field of vision
What do you need?
for your. So it's a glow-in tape, so it has to be in the field of vision for fluoroscopy. As long as you have fluoroscopy view, it's fine wherever you are. It gives you, and it's very hard to say exactly on the vessel where the vessel is, because sometimes the vessel is tortuous, so it's hard to say, but just put in the middle of the thigh, and you can put the view in which it doesn't come in the view. You don't want it to come right in the vision view where you are doing the fluoroscopy. Just on the side, anywhere is fine.
Just loop
Right?
it down.
Yeah, absolutely.
The whole
Well, we're a little concerned about this filter wire. Obviously, there you go.
I think
So now,
yeah.
well, I'm just saying
Just
that
keep-
we wanted to get it down because it's a very bulky balloon.
Yeah.
So what I'm going to do right now is we're going to. So this is the setup, guys, for any sort of perforation. We're first going to prep the stent, which obviously is wiped down. There's no flush. There is a flush on the stent.
I flushed
So
it.
she flushed it. Second, we're going to go ahead and I'm going to hold positive on the sheath. Because when Vishal pulls this bulky balloon, it's going to pull the sheath back. Third, we're only going to fluoro at the level of the filter to make sure that the wire does not come back. You have to accept there's going to be some amount of extravasation into the thigh, okay, which is going to be fine because it's proximal and we're going to be fast. Number 4, as soon as this comes down, we're going to wipe this down. And then Vishal or is going to load the Vibon in, and we're going to go in and deploy. Ready? So now we're going to go double negative down. Always double negative before you pull this large balloon up. So here's the double negative. One more time, Vishal.
Sure.
So you can see the extravasation right there. You ready? Now I'm going to show the filter. I'm going to hold positive on the stent. on my sheet. And Vishal is going to pull. And I'm going to help pull.
Filter. Yeah. Wow.
So you almost got to help pull because the balloon is so large. Okay, and that's why I moved the wire down. Now I have the wire.
Perfect.
Now quickly load the stent. And once we overlap, we're just going to deploy it, and then we're going to balloon it post. And it's more important to cover the proximal than the distal. If we have to put another vibe on
I think it's
distal.
a very good point you made, PK. That you have to expect a little bit of extravasation, which is fine in the mid thigh.
Ready? Yep, exactly. I mean, it's not fine, but nobody wants that. Nobody likes that,
it's not an iliac perf where you have retroperitoneal bleed or anything. It's a mid thigh perf, which is expected to have. But I think
Perfect.
Okay, so now it's a perfect length. I want to thank Karthik for that wonderful suggestion of going with the 150. Okay, right, so there, now we covered it, right?
Perfect.
Now we can breathe. Now we're going to walk it out.
Watch the filter.
Watch the filter again. Remember, Vishal's notorious. See what I said? I think we should call it not the notorious BIG, the notorious VK.
I just
right?
No, who pushed the balloon down? I mean the stand down.
I don't know.
Wait, come down, come back. Okay,
no, you're good. You're good. Are you?
No, we're good. It's just
all right. You're good. A little bit more.
That one's 4-0, right?
no, we are already.
There you go.
Okay, good.
All right. So now we got to understand, this is a lot of fun. So now rather than go with I'm going to change my mind to piss off Damien. I'm going to go with a 6015 Viatrac.
Forget it.
The reason I'm doing this, Karthik, is that I'm worried that the 035 balloon may not cross this stent right now. So I'm going to go with a Viatrac, and I'm going to
He's
just
gonna get
balloon
a
it with a
new balloon.
Viatrac, and then we'll take a picture.
So you're technically all, if you look at it, it doesn't look intraluminal. The way
I think it's
The-
intraluminal.
I guess
I
the
really
vessel
do.
size is 5
Because remember, it went straight here, Vishal. Remember, we went with the straight wire. We didn't go with the curve here. Remember, we
True.
went straight all the way down.
down.
You know, you're right. There's no way of knowing, but remember, we didn't have a loop in this area.
So probably
It's
the
all
vessel size is 5.
calcium and nasty. It's just nasty.
Makes sense. Yeah.
Remember, you said to go with the straight.
Straight wire. Yeah.
So I guess, you know, what Dr. Kapoor and I are talking about is how we cross this lesion. So now we're going to go ahead and balloon it, which is what we're doing here. And I want to be very clear. This perforation was caused by the balloon angioplasty.
Yes.
And I think part of the reason that happened was because she had pain with the Rotarex and we didn't prep the vessel well. I think if we had prepped the vessel well with the Rotarex, we might have had a lesser chance of perforating this balloon, this stent.
Okay.
So again, look at Vishal. Again, he's watching the filter, right? And not once.
Hold on,
This is a monorail balloon.
Monorail.
1 second, wait, I know.
Okay, as soon as I go down and get both, and that's another reason I went with this car, because it's monorail. I got both. I got the monorail balloon, and now I can't blame him.
Yeah.
And I'm going to bring it down, and I'm just going to go up to like 10, 15, whatever we need to go up to.
I mean, it's a covered stent. You can
What
go up
size?
whichever you want. I don't think it
Go for it.
matters
Go.
at this point of time.
Yep, go up. We just want to make sure we expand this now.
What size is this?
6-0. Go
No,
to
but
10,
I'm
12.
missing the length.
So I
10,
don't know,
12,
PK, if it's
14.
16,
I don't know
18.
if you
16,
think it's
18.
what do
Yeah.
you think, Sardar? You think if you did it with Rotarex
Go to
Prep, you
20.
wouldn't have had the perf?
I mean, yeah. I don't think that the
20.
Rotarex was the mechanism of.
No,
of-
definitely not.
perf-
Definitely
Yeah,
not.
yeah, definitely
Down.
not. I think it's definitely angioplasty,
Go up
but I
here.
think it's if you look at her popliteal distal SFA size, right, it looks more like
20.
a 6-0 vessel. So we used a
22.
1-to-1 balloon.
22.
We used it for the
Yeah.
purpose that you want a good expansion, you don't want an underexpanded stent.
Now I want a Dorado.
You have to bite the bullet and take the
Four.
evil.
Yeah,
You have to understand that this will happen,
Down.
and you have to be ready for it. And I think we were ready for it.
Yeah, I think you just have to see how the balloon, how
Yeah,
in any
28, 30.
PTA we see how the balloon
Down.
responds.
Yeah,
You could
I
see
would
the
prefer to
proximal
have
end.
this than have an underexpanded stent and have this all over again, doing all over again. So
Absolutely. Yeah.
Now remember that, look, covered stents have their role, but we want to
Yeah.
really expand this. And you can see here, it still hasn't expanded to that level.
Yeah.
So we need to go back with a high pressure balloon like a Dorado, and then balloon it again, which is what we're going to do. Down, we may even go with a 7. We'll see. Go up here.
see, your true size is right where the centimeter mark is. That's where it
I
looks
think
like
so.
a true
Crank it.
size is.
Crank it.
Yeah.
20.
It is tapering down
30.
here, actually.
Yeah.
I mean,
Down.
I mean,
Yeah,
I also remember we caused a pretty significant subintimal tear and probably a small hematoma behind the vessel wall. That's probably that's the reason for the outpoaching you see. So her true vessel size is somewhere around like 14, 15. That's where her vessel looks like. It's 6-0 vessel. So
Okay, I got it. Let me walk it out.
Okay. Look.
Dorado, guys. So now this is
Yeah,
going to
the
be
wire?
where we're really going to blast.
Oh.
So we'll go with the 60150, and we're really going to crack this baby up.
How about we? We don't. The real question is the distal
the
end of the
DCB.
stent.
Now whether we DCB or not. So
No, my question
the good
is
thing is the
outflow,
patient is
where
not
the
complaining of
collateral
pain
was.
also, right?
well, I think Elizabeth's turned off the max. We're going to turn it back on now.
Yeah.
Yeah,
Either
we're gonna turn it
Liz
back
did a
on
great
now.
job with the sedation, or our patient is not having any pain right now. So,
Oh,
We'll see.
yes.
which I'm assuming
Sorry, Bob. Yeah, no, I
either of
don't
them
see
would be a compliment
I'll
to
go
the
slow.
team. So,
Yeah.
Yeah.
Hold on 1 second. 1 second. Okay, go.
Okay, good. Now we're going to crack again. Now this one, we're going to really try to break it.
Six,
8, 10,
eight.
20.
this is a 7-0.
6-0.
6-0.
20, 20, 30, 40, 50,
55.
80, 100. Okay.
Offer.
So she's actually doing the expansion now, right at the number 5. So you can see it expanding well, and slowly the stent is expanding at number 5. It's coming down, down, down. You see the luminal gain there. So
yeah, down.
So
We're gonna have to go with this maybe 6.0 shorter. 6.080 balloon down.
So that's the advantage of having a covered stent.
Well, we still remember covered stents sometimes give you a false sense of security.
Yeah.
You know, I'm gonna fix again. I'm fixing the sheath, right?
PK, you want to explain what that false sense of security is?
So you could tear the lining of the covered stent, right?
Yep.
You're gonna have to go double negative.
Yeah. No, it is.
So you know.
And you can form a hematoma behind the covered stent with a small luminal connection, just like any aortic graft or anything. You can always tear the material and have flow behind the stent strut, and then patients can have local pseudoaneurysms behind the stent struts with the cloth, and then have a leak.
Okay, 6.080 now.
Start having local pain.
Yeah.
So I'm gonna go with an 80 now. I'm just going to go with an 80. Give it a little puff.
So
Michelle,
that's the reason probably
sure.
Sardar PK is not going with 7.0 because he probably doesn't want to tear the vessel. I think.
Yeah, so I'm going to go.
Very good, actually.
Yeah, I'm going to go with just 6.080.
Just right at that from 5 to 10. That's what
yeah, I'm just planning on just doing it more local focal rather than dilating what we're already dilating, and get a 7.082. And guys, again, same thing, right?
6.080.
6.080. What we really want to do is try to expand this, and obviously we don't want to keep expanding what we've already expanded. So, and you can see up top by the centimeter mark or 2 centimeter mark, a little bit of a outpouching more. So that's enough. We have to go from like 5 to like maybe 10.
10, yeah.
Yeah.
Or like 12.
Maybe a 12. So again, as I advance this, I'm going to watch my filter, right?
Yeah, well.
And again, this is a pretty complex case. We did Rotarex, we have a perforation, all sorts of stuff is happening, and we were basically an hour and 20 minutes in, and most of the time Vishal was talking, so it's very tough, right? So we're here. He's going to beat me up later. All right, ready?
7 of 40, 40, 80.
Okay, right there.
Perfect.
All right. This is so question. Would anybody go with the 7 or would you IVUS?
I would not go with the 7.0.
I would not go with the 7. I'm happy.
I don't think there is any reason to IVUS either. So
10, 12, 14.
18, I think we did 20, the maximum expansion
20,
with a
22, 24, 26, 28.
My balloon burst.
Okay, balloon burst. That's a bad sign. Down. Oh boy. Oh, okay. Let it just come down.
Yeah.
So the balloon burst, and now this is a major issue. Yeah. So now you want the balloon not to. It's already a bulky balloon, so you always want to leave it on negative. You never ever want to go back to neutral. Yep. Leave it on negative. Okay.
Yep.
So now the balloon is burst. So now we're gonna come out slowly, and I am gonna watch my filter first, and then talk to Vishal as he comes out. If he's having trouble at the level of the sheath, then I'm gonna start pulling. Which I'm going to start pulling now.
I'll just explain why you're doing that. I think, if I'm not wrong, PK, you're concerned about the balloon, like the material of the balloon sticking to the covered stent, right?
Basically, what you're worried about is accordioning of the balloon.
Correct.
Yep.
You don't want it to accordion at the tip of the sheath. Now we're going to do a DSA, because as we know in the coronaries, if the balloon ruptures, even you could have a perf. Unlikely here because you have a covered stent, but again, you want to be careful.
Very good flow.
So I think we leave it alone.
I agree.
Yep.
Okay, so what is that? That's a vein, so we're good. Venous phase there, we're good. Okay, now let's capture the filter. Ready, mag up on the... So another thing I want all of you to do is, when you capture the filter, you want to go ahead and do a mag up filter shot, right? And under non-DSA.
It is non-DSA.
Okay, again.
One second. Okay.
All right. Okay.
Good.
So we want to make sure that we don't have any issues going on here, which we don't. Filter is not full. Very good. So we're going to capture it. And then now we have to finally decide what we're going to do with the
distal end of the one.
With the distal stents and the distal end of the Zilver. And then we can take it from there. So
you would want to decide that and then take the filter out, or?
No, I think at this stage, Karthik, I think our chances of embolization are very low. I think we're not atherectomizing anymore, right? Mm-hmm. I think if anything, we're going to need support to go in and grab past these bulky DCBs through, right? The nice thing is Lutonix and Medtronic, I believe, both come in 0 and 8 right now. So you have that option. But I think right now we should IVUS. So what I'm going to do is I'm going to capture the filter, right? So there's the full capture of the filter. I'm going to leave this. The advantage of the EmboShield is that you can leave the wire down. Right? I'm going to leave the wire down. One of the advantages of the EmboShield is compared to the Spider. The advantage of the Spider. The advantage of the Spider is that the Spider is very large.
So just want to make sure that's a live demonstration of how the wire is pulled, and
I just want to show you
PK
that
was doing that.
I just want to show you that was done to show you how to get the loop and get the wire down, Karthik. See how smooth that was?
Very smooth. I think Vishal is also trying to say the same thing, that you were very smooth.
Very smooth.
Right, Vishal?
Oh my God.
He was complimenting you too, Pigas.
Exactly.
He's always mad at me. All right, let's do the IVUS.
So, PK, I'll just ask Sardar is here. I mean, while you guys are working, Sardar, what would you do? This form of platelet therapy, antiplatelet therapy would be anticoagulation. You would want to start Xarelto, Plavix, something
That's
else.
a very good question. I mean, this patient was already on an advanced antithrombotic therapy with a DOAC in lower dose and on Plavix as well. Yeah. And this happening on this therapy is already an indication for a high atherothrombotic risk for this patient. Yeah. So I would continue probably with dual therapy, right. Maximize the LDL lowering capacity. If not achieved below 70, I would maybe probably in this patient go below 50, as the European guidelines would suggest. So Repata might be an option for this patient, or alirukumab.
I thought it was a
Interesting.
See, hoped.
Especially because you think there's a stenotic component to it, atherosclerotic component.
Okay, we're going to do a pullback here, guys, okay?
Go like record.
Record. A lot of plaque distally.
Yeah.
Dissection. Let's see where that is.
That's probably right where the distal edge of the stent is.
Yeah. Right.
Looks like, because I can see the stent struts shadowing there. So
and there's the stent.
And now
a lot of ISR, like Vishal said, a little bit, not a lot, a little bit, but it's there. Right clearly there. So now the option is, you see the proximal stent also has some ISR, more minimal than a lot. But remember, we did rotarex this part, right? So it looks like distal ISR with dissection of the stent. And now we're going to go into the Viabon and look for infolding. I don't really see a lot of infolding. It's actually pretty well deployed.
I know, it's very well sized.
Yeah. I don't see any, a little bit of infolding there, but we're going to put it on.
Yeah, right there a little bit. I was about to say, but just a little bit, PK. I think it will settle down by itself.
Proximal stent is gorgeous. A little bit of ISR. Yeah. So Vishal was correct. So now the question is, do you do DCB distal, and how do you deal with the distal dissection?
Dissection.
I'll just... No, I think personally me, I would just do a DCB, and if it's non-flow limiting, let it heal.
No, I think we stented, Vishal. I think you've got to stent the distal dissection because your entire outflow is dependent on that.
I agree with that.
Don't you think?
Especially because you put a Viabon there now. So I think it's more important that you stent it.
Put another drug for it.
Yeah, so why don't you guys give me another Zilver? Give me a 6040 Zilver.
PK, I think it's important to know why stenting is important, not only for flow, but the way the dissection looks. If you look at it, it's a separation from the vessel wall. It's a free-floating dissection, actually.
Yeah.
The distal part of the distal edge of the whole layer, like you see that, like they're right there. You see that the flap is like completely lifted off from this side. This is...
I don't know.
So maybe you put a bigger one. But I don't know. Where do you put it? Because the dissection was right around the collateral.
Well, yeah, I would just go beyond the collateral and just put it.
Okay.
Yeah, I would cover that collateral. I think it's fine.
No, you have to cover the collateral because the dissection
but then you're going to land in a diseased area. But I think this is where we don't know. In the coronaries, we would say, let's not do this. We'd cover it. But in the periphery, how many stents are you really going to put? So
I would just put one.
I just put a short 40 stent.
Yeah, that's what I would do.
Yep, and then be done.
That's it.
Or are we going to put a 60? You have a 60, Damien? Because 60 would cover that. 60 would cover that area.
You can go to the next collateral.
Exactly. Go to the next collateral and land it. Let's get an idea.
Because I don't think this DCB will take care of this kind of dissection. This is a little bit more.
Well, again, I think as Sardar and I have been really looking at what's going on, we're trying to figure out why DCBs fail. Oh, that's such a small vessel.
Yeah.
That's what I'm saying. It's a small
vessel. Let's just do a 40. You agree now? We should just do a 40?
Yeah, just stack
It's such a small vessel, man.
I would go with still 60 PK.
Yeah.
Yeah.
Sardar?
I would go with still.
I agree.
60. Take a 6060, have a nice step down. I think it should be fine.
Yes, sir?
No. Roadmap.
Oh, sorry. Yeah.
All right, 60.
Yeah. I would go to that collateral, the next collateral, and
it's going to be beyond that, though.
Yeah.
But that's okay. It's going to look like a little step down.
Yeah, I mean, that's normal.
Right by the edge of that distal genicular collateral. That's what I would do.
Agreed. And then would you guys DCB this?
We already have a silver.
Probably not. I don't see that much amount of restenotic tissue.
Okay. So what we'll do is we'll put the silver in. We'll call it a day. Again, I think this is a great case that shows, the difficulties in decision making because of the lack of data that we have. However, we were able to demonstrate the challenges in these cases for everybody at home to understand what are the decisions that you make. Obviously, a lot of good fun between me and Vishal, but the reality is all those little things we were poking fun of each other at was the reality. You can't pull the wire back. You got to be careful of the wire. You got to be careful of the filter and how the filter behaves, right? And so on and so forth. So I think we go up to here, right?
Yeah.
I don't know. Do you want to go until there, PK?
Well, it's a 60.
It's a 60. That's why you wanted a 40.
I know, but you can always reline the stent, right? It's okay. I don't think there is any problem relining the stent with it. But
I agree.
I can pull back right there then.
That's good.
Yeah, right at the proximal edge of that. You want to take a puff and see?
Well, we
cover the distal collateral.
You can't see.
You can't see.
Probably you can roadmap the previous one,
Okay,
previous picture.
scene minus.
So it's right at
how do you roadmap?
Right at the P.
Right at
the distal edge of the P.
Ray, how do you roadmap?
Not in this room. You can't.
Yeah, that's fine. You can go by just P.
Right at P.
We shall go by the P.
I know. That's what I was telling him. Go by the P and it should be fine.
Yeah, that's perfect.
Perfect. Okay.
It's perfect.
Grazie. But I think all those things that I was highlighting with Vishal, it's very, very important. Watching the dynamic between the sheath, preparation when you do have a perforation. How do you deal with the perforation? What are the steps that you want to do when you deal with the perforation, and take it from there. So as we expected, it's a very diseased vessel distally.
Yeah.
So now we have to balloon back with the 6015. Give us the 6015 Viatrack again. A new one, and then we'll be done in a second. So I guess with this we can do offline. So Karthik, we're going to do a final, a quick shot of the foot to show everybody that this is done, and then we're just going to balloon this, and then we'll post the final online here. I'm just going to show you our stuff here. Vishal's going to put it on DSA. I want to show you that there's good runoff, no perforation, so on and so forth. So you can see here, very good. It actually beats the DSA down.
Yeah.
And I don't know what happened to our DSA, but anyway.
Hold on.
I think it's a great shot.
We're good.
We're good now?
Yeah. Subtract on. I think it was roadmap. That's why the thing just closed out.
Yep. So I want to make sure there's no wire perforation. And then there is no wire perforation. Yeah. And then the foot will be fine. So while I recap, I'm going to ask Vishal to go ahead and do the stents. I'll do the balloon of the stent, and you can put it on the side. So again, I think this is a great case to highlight the decision-making challenges that we have regarding the use of different devices in in-stent restenosis. There is some available data out there with the laser and some DCBs, but really, the long-term efficacy in lesions that are real-world lesions, such as the one you just saw, is really lacking. So I think what we have to do as endovascular interventionalists is really try to marry the data with the available experience and do things safely and make some decisions that are based on safety first, priority being safety, and second, obviously, whatever the available data is, so we can extrapolate from it. So at this stage, since there's no head-to-head trials, and we have used multiple other devices in the past, we decided to go ahead and use a Rotarex device, which again, as I said, was off-label in the U.S., but it's on-label within Europe. You can see that we achieved a wonderful result in terms of luminal gain, clearing out plaque as well as clearing out thrombus, and I think that's going to be the part that's very impressive, as you saw in IVUS, with the very minimal plaque remaining. We also postulated on the mechanism of failure regarding why this failed, and why this failed was it the stent or was it the normal segment? And with the difficulty of expanding the normal segment and how clean the stents looked, we felt it was really the normal segment. And so we aggressively ballooned the normal segment, resulting in a perforation, and we quickly demonstrated how to use a covered stent without having any antecedent complications. So I think this case is a good demonstration. As far as going out and follow-up, we'll go ahead and put her on dual therapy with Xarelto as well as with our NOAC along with Plavix, and then we'll check her for Plavix resistance, and we'll also do serial ultrasounds to make sure that the patient we capture any early in-stent restenosis. So with this being said, future therapies for this will remain to be seen. Hopefully this will be enough for her to do well and then go on. So we'll take a final picture here of the stent.
Yes, sir.
And I want to thank you very much. We'll see you on March 24th. Karthik and Sardar, if you could, I'd greatly appreciate you finishing up. Thank you. Okay. Thank you, Vishal. Thank you, guys.
Thank you, sir. Looks beautiful.
Foot shot.
One foot shot.
All right, guys. So I think it's Dr. Krishnan, Dr. Kapoor, Shreya. I think it's a great case, done very well in 1.5 hours. I think with all the talking and discussion and everything, very complicated case done. As PK said, I think it's very important to understand that these kind of cases will take time. You just have to take your time, make the decisions, understand what kind of complications you can expect, and be ready for it. That's the major part of it. And if you guys have, and I know there will be a lot of questions which will come through because of this case. We'll be more than happy to answer the questions. Take your time, review it. I'm sure you'll get a lot of these cases in your practice. That's what we are here for, to guide you through it. And any questions you have, we are more than happy to answer it. And you can always go into our archive. This case will be archived into our website by the end of the day, if I'm not wrong, with the IV team. And then we'll see you guys again next month, fresh and early on March 24th. That's the last Wednesday of the month at 8 a.m. Thank you guys.
Very much.
Bye.